Bismillahirrahmanirrahim. In relation to the topics of the cell injury, today we discuss about pathologic calcification. We know that deposition of calcium or calcification is very important physiologically, and sometimes in pathological conditions there may be abnormal deposition of calcium that we say is pathologic calcification. Now, before we go to discuss derangements of pathologic calcification, we briefly discuss about the calcium. And the calcium, as we know, it is the most abundant mineral in the body. Normally, the calcium is kept in a very narrow range from 8.5 to 10.5 milligram per deciliter, and in children, growing children, the concentration is a little higher. We know that calcium is involved in muscle contraction by through sodium depolarization, and we know that calcium is important for activation of certain enzymes. Physiologically, calcium is needed for the formation of both and teeth, and calcium has got a very important role in blood clotting. We know that when we take the blood for the purpose of certain tests or for the purpose of blood transfusions, we add oxalate or citrate, and this oxalate or citrate will catch the calcium in the blood, and without calcium the blood remains in a liquid form and it doesn't undergo coagulation. Calcium is also needed for the normal heart rhythm. So, calcification is the deposition of calcium salts. Pathologically, we can define pathologic calcification as abnormal deposition of calcium salts together with small amounts of iron, magnesium, and other minerals. So, physiologically, calcification occurs for the development of bone and teeth, and as we know that calcium is needed for many cellular biological processes, but pathologically, if there is abnormal or excess deposition of calcium in the tissue, we refer it as the pathologic calcification. We divide pathologic calcification into dystrophic calcification and metastatic calcification. In dystrophic calcification, what happens that calcium is deposited in necrotic, dead and damaged tissues. Now, in dystrophic calcification, the normal calcium concentration in the blood is maintained. It is normal. There is no derangement in the calcium metabolism. While on the other hand, in metastatic calcification, what happens that there is some derangement in calcium metabolism, particularly in conditions leading to hypercalcemia. And due to excess calcium level in the blood or hypercalcemia, calcium deposition occurs in normal tissues like lungs, blood vessels, stomach, kidney, and other tissues. Now, dystrophic calcification usually we see during routine investigations, particularly when we take an X-ray of a person with previous pulmonary tuberculosis, we may see calcified lymph nodes. So, itself, dystrophic calcification, mostly it is a sign of previous cell injury. However, in certain conditions, particularly if it affects the blood vessels and the heart valves, it may cause organ dysfunction. So, dystrophic calcification occurs in areas of necrotic cell death, and usually when there is tissue injury, it leads to inflammation, and in irreversible injury, there is cellular necrosis. So, if dystrophic calcification may particularly occurs in the atherosclerotic areas where atherosclerosis is found, and we know that atherosclerosis is abnormal deposition of cholesterol and lipids in the blood vessels wall, which may cause narrowing, and sometimes the atherosclerotic plaques may give rise to thrombus and embolus formation. So, atherosclerotic areas in the aorta and large arteries are the very particular sites of dystrophic calcification and abnormal calcium deposition. And sometimes, with the advancing age, and particularly if the heart valves are damaged by any disease, there is excessive dystrophic calcification, which not only indicates injury in these sites, but sometimes if it is severe, it may cause abnormalities. Now, how dystrophic calcification occur? We divide dystrophic calcification into two phases: the stage of initiation and the stage or phase of propagation. We know that our cells have phospholipid bilayer cell membranes, and this phospholipid bilayer membrane of the cells contain phospholipids. Now, sometimes during injury, what happens that certain enzymes known as phosphatases, they are released, and these phosphatases act on these membrane phospholipids and liberate phosphate. Now, calcium in the nearby areas bound to this phosphate, forming the the crystals of calcium phosphate. So, calcium abnormal deposition may occur either inside the cells or outside the cells. Extracellularly or outside the cells, the calcification is seen in membrane bound vesicles from degenerating cells. And as we say that the phosphatases act on the phospholipids liberating phosphate, and the calcium in the surrounding area bound to this phosphate, forming the crystalline calcium phosphate. We know that inside the cell, the calcium is deposited in the mitochondria and in the smooth endoplasmic reticulum, and it is stored there, and when the calcium is needed, it is released at the time of when the action of the calcium is required. So once initiation occur, what happens that then the calcium and phosphate uh, continue depositing uh, around the initial calcium phosphate crystal, and in this way the phosphates and calcium form circular whorl masses in the form of abnormal dystrophic calcification. If we remember that in papillary carcinoma of the thyroid gland, we see the samoma bodies, and actually the samoma bodies are deposition of calcium, oral deposition of calcium around the phospholipids. Now, when we treat the tissue with He stain, hematoxylin, and usine stain, we know that usine is the basic stain, and the hematoxylin is the basic stain, and usine is the acidic stain. And various cell components have affinity for the basic or for the acid stain. Mostly hematoxylin stains the nucleus, while the usine stains the cytoplasm. So the crystalline calcium or calcium phosphate have an affinity for the basic stain, the hematoxylin, and these areas are stained blue by the basic hematoxylin, and under the microscope they appear as bluish areas. Now, calcification in atherosclerotic plaques and heart valves is very important, because we have discussed atherosclerosis, that it is the abnormal deposition of uh, lipids, cholesterol in the enchyma and smooth muscle cell of the blood vessels. Now, actually, the process of atherosclerosis starts with endothelial injury and oxidized VLDL particles lead to activation of the macrophages, and the macrophages engulf the fats and they become foam cells. And as the macrophages, these fat laden macrophages, when they die, calcium is deposited in the vessel wall of the mostly large and medium sized arteries. Here we can see that there is a concentric type of calcification, and this will lead to arterial stiffness. And this type of calcification particularly occurs in endothelial injury, which is followed by the atherosclerotic deposition deposition of atherosclerotic plaques, which mainly consist of cholesterol and other lipids, and this may affect the vascular smooth muscle cells. Now, since the calcium has an affinity to deposit in necrotic, dead and damaged areas, so what happens that the calcium phosphate is deposited in these necrotic and damaged areas, leading to dystrophic calcification. If it occurs in a concentric form, it will lead to stiffness of the arteries, and elasticity of the arteries is lost, and the vessels may become narrow. However, in certain conditions, if in an atherosclerotic plaque, if calcification occurs, it may not be concentric, but it may be in the form of an eccentric mass, and it is uh, very dangerous for the formation of thrombi, and these thrombi, if they become detached, they may go in the blood as emboli and can cause various problems. Now here in this slide we can see that calcium are deposited in the aortic valve, and excess deposition of uh, calcium and dystrophic calcification in the aortic valve may lead to calcific aortic necrosis. And the calciums are seen as white, gritty depositions, particularly if we see a tuberculous lymph node which has got calcified. It may appear in the form of a bony or in the form of a stone on grass appearance. Now, as I said, calcium homeostasis is calcium level is controlled within a very narrow range by the mechanisms, hormones and enzymes. Normally, the intracellular level of the calcium is kept very low, and as we know that excess intracellular accumulation of calcium may cause activation of various enzymes that may lead to apoptic cell death. So generally speaking about the calcium, that usually we take about normally 1000 milligram of calcium orally, and about 900 milligram of calcium is excreted in feces. In addition, calcium is absorbed and also secreted from the GI tract into the lumen of the gastrointestinal, into the lumen of the intestine, and is excreted in feces. Overall, we get 100 milligram of calcium a day. So this calcium is found in the extracellular fluid. It is exchanged between the cells and the extracellular fluid, and since bones are the major deposits of calcium, so calcium is deposited in bones, and at the same time the osteoclastic activity continues during bone remodeling, and calcium from the bone is released. So the deposition and absorption of calcium in the bone, they are balanced. Calcium is also filtered through the glomerular filtrate into the urine, but most of the calcium is reabsorbed. And overall, normally on an average level, only 100 milligram of calcium is excreted in urine, and this is balanced by the daily intake of about 100 milligram of calcium in the body. Now, in the blood, calcium mainly occurs in two forms. One form is diffusible forms, which can cross the cell membranes, and the other is the non-diffusible form. The non-diffusible form of the calcium is the form which cannot be used by the cells, and it is usually bound to proteins like albumin and gamma globulins. Now, the diffusible portion of the calcium is the 9% of the diffusible portion of the calcium is bound to complexes forming bicarbonate and calcium citrate complexes, and this calcium can also this calcium can't be used by the cells because it is complex to bicarbonate and citrate. Now this ionized calcium Ca2 double plus. This is physiologically active form of calcium, and this should be kept within a very narrow range because we know that excess of calcium can cause various pathologic events. Now, metastatic calcification, as I said, it usually occurs when there is hypercalcemia, as opposed to dystrophic calcification, which occurs in dead or dying tissues or necrotic tissues. Metastatic calcification leads to hypercalcemia, and there may be calcium deposited even in normal tissues like blood vessels, stomach, kidney, and other body tissues. The most common cause of metastatic calcification is hypercalcemia, when the blood calcium level is high than normal. So, the conditions that can lead to hypercalcemia include the excess secretion of the parathyroid hormone, and we know that parathyroid hormone is the major hormone that controls the calcium homeostasis in the body. Now, if there is excess parathyroid hormone secretion, it will lead to hypercalcemia and elevated blood calcium concentration. And this elevated blood calcium concentration or hypercalcemia may cause metastatic calcification. Now, conditions in which there is excess secretion of the parathyroid hormone include the primary parathyroid tumors and sometimes malignant tumors that secrete parathyroid hormone related protein, which also stimulates the release of calcium from the bones and have similar actions like parathyroid hormones. Now, other conditions that may lead to hypercalcemia may be, for example, there is excess destruction of bone which occurs during accelerated turnover, and this type of situation occurs in Paget disease and when the bones are immobilized, for example, after fracture, and there are other conditions, and if there are tumors that may cause increased bone breakdown, for example in multiple myeloma, leukemia, and sometimes in diffuse skeletal metastasis as is seen in different cancers. We know that vitamin D calcitriol are active form of vitamin D3. It causes increased reabsorption of calcium from the gastrointestinal tract. So, any condition in which there is excess intake of vitamin D, it will increase the absorption of calcium from the gastrointestinal tract. And sarcoidosis, which is thought to be an autoimmune disorder, what happens that in sarcoidosis the immune cells macrophages activate enzyme alpha hydroxylase, and this alpha hydroxylase convert the inactive form of vitamin D into its active form, calcitriol, and we know that calcitriol will increase blood calcium level by increasing the absorption of calcium from the gastrointestinal tract. Now, another condition, we know that the renal excretion of calcium and reabsorption of calcium as well as phosphate, they are controlled by the parathyroid gland, and normally parathyroid gland increases the reabsorption of calcium, but it increases the excretion of phosphate. Now, if in a condition in which the kidney is damaged In renal failure, what will happen that the kidney will be unable to excrete excess phosphate and more phosphate is retained in the body. Now, when this excess phosphate is available in the body, what happens that it will bind calcium, and do the total calcium level in the body is normal, but the phosphate will catch excess calcium in the form of calcium phosphate, and the resulting hypocalcemia will activate the parathyroid gland to increase the secretion of parathyroid hormone known as the secondary hyperparathyroidism. Now, as I said that hyperparathyroidism uh, is the condition which causes hypercalcemia. Parathyroid gland is strongly associated with the calcium homeostasis and normal metabolism in the body. So in any condition, if when there is excess parathyroid hormone secretion, it will lead to hypercalcemia. Normally, the parathyroid hormone increases the absorption of calcium and phosphate from the gastrointestinal tract. The second effect of the parathyroid hormone on causing hypercalcemia is the rapid release of calcium from the bone by causing bone demineralization and breakdown of bone and release of the uh, calcium into the blood. So, coming to the kidney, the parathyroid hormone increases the reabsorption of filtered calcium, and it decreases phosphate reabsorption, causing phosphate excretion, and additionally it also decreases the bicarbonate reabsorption. So the parathyroid hormone is also it activates the through an enzyme known as the alpha hydroxylase, and it causes alpha 1 alpha hydroxylation of the 20 hydroxycholecalciferol into its active form known as the calcitriol or active vitamin D3. So as a result, when there is excess parathyroid hormone secretion, there will be increased plasma calcium concentration, while the plasma phosphate concentration is decreased because parathyroid hormone increases the excretion of the plasma phosphate. So basically, the hyperparathyroidism will lead to hypercalcemia, and uncontrolled hypercalcemia will lead to metastatic calcification or abnormal deposition of calcium. But here, the there is hypercalcemia, while in dystrophic calcification the plasma concentration of calcium remains normal. But in dystrophic calcification, calcium deposition occurs in dead, necrotic, or damaged areas. For example, the lymph nodes and areas of caseation necrosis in tuberculosis, and it may also occur in areas of coagulative necrosis, in areas of lymphatic necrosis, fibrinoid necrosis, and also in gangrenous necrosis sometimes. So, any type of necrosis can lead to the deposition of abnormal uh, uh, deposition of calcium in the form of dystrophic calcification. Now, the calcium, as we said, is very tightly controlled. First line of defense of the calcium control are the bones. When there is a need of calcium, the exchangeable calcium from the bone is released into the circulation. When there is excess calcium in the circulation, calcium is along with phosphate is deposited from the extracellular fluid or from the blood into the bones. The parathyroid hormone, briefly, as we said, that it will control calcium phosphate level by increasing or decreasing the release or exchange of calcium between the bone and extracellular fluid. It may also activate the inactive form of vitamin D into its active form, active vitamin D3 or calcitriol, which will increase intestinal absorption of calcium and phosphate. And the third effect is on the kidney, where the parathyroid hormone increases calcium reabsorption and excretion of phosphate. When there is excess calcium in the blood or hypercalcemia, it may lead to hypercalciuria, excess formation of calcium in the urine. And hypercalciuria or excess excretion of calcium in the urine will lead to dehydration. And dehydration, along with the presence of excess calcium in the urine, may lead to the formation of calcium oxalate bones, calcium oxalate stones. Sorry. Now, we come to know that metastatic calcification is caused by hypercalcemia, and it will be caused by hyperparathyroidism and sometimes uh, tumors and malignant tumors, and they secrete the parathyroid hormone related peptide which has a similar action on the like the parathyroid hormone. And in conditions of excess breakdown of the bone, for example in Paget disease, and when the bones are immobilized for long times, and tumors like leukemia and multiple myeloma. And vitamin D intoxication, when there is excess vitamin D, it will increase the absorption of calcium from the gastrointestinal tract, and this type of condition is seen in milk alkali syndrome, in which some people ingest lot of milk, and they may get themselves exposed to vitamin D intoxication, which will cause hypercalcemia and increase concentration of calcium in the blood. The renal failure, in renal failure, what happens that normally the parathyroid hormone causes increased excretion of phosphate. But if the kidney is damaged and phosphate cannot be excreted, what will happen that it will lead to retention of phosphate in the blood, and this phosphate will bind calcium. As a result of the binding of the calcium to the excess phosphate, there occurs a false hypocalcemia, and this false hypocalcemia that we will discuss in detail when we discuss the parathyroid gland disorders. But here simply that this induced phosphate induced hypocalcemia will stimulate the parathyroid gland, and the parathyroid gland will start secreting excess parathyroid hormone to compensate for the hypocalcemia, and this type of situation is known as the secondary hyperparathyroidism. Calcium salts, on gross examination, they are seen as white fine granules or clumps, and they are often felt as gritty deposits. As I said, that if there is excess calcification in a lymph node, it will appear under the thumb and index finger as a stone. So dystrophic calcification commonly occurs in areas of necrosis, and it is also seen in areas of caseation necrosis that are seen in tuberculosis. Metastatic calcification occur anywhere, but particularly it affects the interstitial tissues of the blood vessels. It may affect the kidneys, lungs, and gastric mucosa. And if there is excess calcium in the kidney, and if excess calcium is secreted in the urine, it may lead to renal damage. On histological examination, calcification appears as intracellular or extracellular basophilic deposits, as they have strong affinity for the blue hematoxylin stain. Here we can see the calcium deposits which appear blue, and this slide is taken from the alveolar walls of the lung in acute pneumonitis. Thank you very much.